colorful. So coming to the next presentation, the clinical profile and treatment protocol of accommodative spasm in Indian children and young adults by Dr. Prajna GHOSH.
Good afternoon, everyone. So I'll be speaking about clinical profile and treatment protocol of accommodative spasm in Indian children and young adults. I am Dr. Pragya. So history goes back in 1884 when Fitzgerald noted this condition and mentioned it to be very rare. Later on, Patton described it as sudden onset apparent myopia in one or both eyes, which disappears on atropinization. In 1922, Prajna published 30 cases, among which 6% patient had convergent strabismus, but he denied any significant association. Kogan later coined the term spasm of near reflex, and he differentiated convergence excess from accommodative spasm. So our study was retrospective and descriptive study. 50 patients, 100 eyes were evaluated for 2 years, and we took detailed history and orthoptic evaluation, including undilated and dilated autorefraction, cycloplegic retinoscopy, fundus evaluation was done. On post-cycloplegic test day, we also performed modified bodies delay test. 24 male patient, 26 female patient, aged between 10 to 30 years, and their presenting complaint was for 66% patient acute onset esotropia and diplopia, 64% patient complained distance vision blurring, 48% patient complained near and distance vision blurring, 54% patient presented mainly because of headache, and 10% patient came for routine checkup. So orthoptic parameters were very much variable with a huge range. Predominantly NRA to be on lesser side, positive relative accommodation higher side, accommodative facility was less, and undilated refraction was very variable with vacillating reflex and mainly myopic. Cycloplegic retinoscopy was stable and low hypermetropic. Predominant accommodative component was present in 48%. Predominant convergence component was there in 18%. Both component was there in 34% patient. So we treated them 4% with hyperopic glasses. There was no recurrence. 4 patients, that is 8%, we treated with orthoptic exercises. 1 patient recurred and needed cycloplegic. Most of the patient, that is 88% patient, needed all of the treatment like cycloplegic, glasses, and orthoptic exercises. 8 patient recurred and needed stronger cycloplegic. 9 patients had persistent ET for which they needed surgical correction. So treatment aimed at taking care of triggering factor followed by conservative methods, and in case of any case of persistent ET, needed surgical correction. So we got to know about resolution, relapse, and recurrences. When patient was symptom-free 4 to 6 weeks after stoppage of treatment, that was a resolution. When patient was never symptom-free, and whenever we are trying to taper the treatment, symptoms were deteriorating, it was a relapse. And when patient was okay for 4 to 6 weeks after stoppage of treatment, but again later on it came back, that was a recurrence. So already we knew that accommodative spasm was a part of SNR, that is spasm of near reflex, but our study emphasized on the role of excessive screen exposure and psychological stress to be important risk factor, and we also got a clear idea about resolution, relapse, and recurrence, and how to treat accordingly. And treatment might be time consuming, but it is curable. So to conclude, accommodative spasm is not so rare, but definitely less documented. Diagnosis and treatment may be time consuming, but it is curable. Systematic approach is required to come to a diagnosis, and assurance and patience are the key. Thank you.
So you told that prevention of screen, like how you will go ahead, it is giving to accommodative spasm.
Yeah.
So everybody is exposed to screen. How are you going to stop it?
No, so that is part of basic lifestyle modification. So I first to figure out what is not necessary, what is not required screen time, and try to cut it down. Sometimes simply we just scroll our phone for no reason. Those things should be cut down. Which are required for study, for work purpose, if that is not avoidable, we need to maintain visual hygiene, maintain frequent breaks, maintain one arm distance, keep it at your eye level system, make the brightness eye soothing, not too bright, not too dim. The background light should be proper. And after 20 minutes, you need to look at some 20-feet object. At least for 1 or 2 minutes, take some frequent breaks. So all those things should be maintained, even if we can't completely avoid screen.
Nowadays, newer modalities are there for digital de-stress. Have you tried those?
I didn't get, ma'am.
Digital de-stress modalities, are you aware about? I think you must be aware about it.
Digital distressing,
Yes.
like there is some time after lock time,
No,
you're
no,
telling?
no, there are computer exercises.
So those are orthoptic exercises.
Yeah.
That can be done. That we do. We have VTS4, office-based therapies we give. Yeah, that is there, even with Binox.
Right, okay, office-based. What about home-based therapies?
Yeah, that's what. So initially we start them with home-based therapy. Like
What
we
is
can,
it like?
so we can give heart chart and accommodative flippers, accommodative rock. These three mainly we can give them at home to do, and simple some divergence exercises we can give them. So we give them usually 2 weeks or 2 weeks interval, we check them back. If with home-based therapy they are doing fine, we continue with that. But if we see it is not really helping because not many things we can advise them to do at home, then we call them back for office-based therapy. And mainly we do VTS4 and
Okay, have you
Binox.
tried Binox?
Yes, Binox
How are
de-stress
the
therapy.
results? That is, I think, the easiest available technique nowadays, and it is giving very good results. So what about you guys?
Yeah, result is good. But mainly what my take on in this accommodative spasm is, mainly first we need to stop the triggering factor. As you correctly mentioned, we keep de-stressing therapy here in office, but they are not maintaining the same thing at home. Then it doesn't work. So we just need to tell them however triggering factor should be stopped. But if you ask only about the therapy, therapies are doing good.
Yeah, so Binox is a home-based therapy, not an office-based therapy.
No, first once we teach them at home.
No, it's everything done at home. We are giving at home directly to the patients.
We teach them first in our institute, then we monitor them. Okay. We give them at home, and after 30 session, after 10 session, we call them if they can come. If not, after 30 session, we call them back and recheck.
And what about cycloplegic glasses? They were just 0.5 and plus.
Cycloplegic glasses.
You mentioned three things. Hyperopic glasses, second is orthoptic exercise, third is cycloplegic glasses.
Cycloplegic glasses, no, cycloplegia. Yeah. Like, so on post-cycloplegic test day, we do modified bodies delayed test. So suppose patient is taking 0.5 to 0.75 for distance. Along with that, if it was very strong spasm, I would like to give him some homatropin 2% drop twice daily. Then I need to give him bifocal glasses, plus 2 or 2.5 for near, 0.5 for distance. So it will be a bifocal glass along with that 2% homatropin so that he can carry out his day-to-day activities. Because the child needs to read also, do his things.
So that means the accommodation is not breaking with cycloplegia?
Yeah, sometimes it is very strong. With first cycloplegia, it doesn't go.
Have you tried atropine also in that?
Yeah, so this I'm talking about which breaks with first cycloplegia that day. But when I'm calling back for post-cycloplegic test day, again I'm seeing the similar kind of spasm is starting in. Anyway, this modified bodies delayed will also break and make the eyes relax. So then I prefer to give them bifocal glasses and homatropin and call them back after 2 weeks. But sometimes we see even after that the same spasm has come back. Then we categorize this as severe spasm, and for them twice weekly atropine we give.
Okay, thank you.
Thank you, ma'am.
I think message is clear to all of you. I would ask whether you would like to comment anything on the day one give atropine in spite of homatropin, waiting for so long, waiting for 2 weeks, then again calling the patient. It's not easy for a parent to get the child. So it's a simple question, whether can we go ahead directly with atropine on the first visit? Because that is the best cycloplegic available.
Yeah, that's true, ma'am, but most of the patient didn't require them. Only 1 or 2 patients. Homatropin was enough.
But we are cutting down the visits of the patient. You're getting my point?
Yeah, that's okay. Yeah, I understand.
You can have a discussion with Jyoti and let me know. Okay? Thank you.